Good afternoon. My name is Stephanie, and I will be your conference operator today. At this time, I'd like to welcome everyone to the National Learning and Action Network conference call. All lines have been placed on mute to prevent any background noise. After the speaker's remarks, there will be a question and answer session. If you'd like to ask a question during this time, please press star, then the number 1 on your telephone keypad. If you would like to withdraw your question, please press the pound key. Thank you. I would now like to turn the call over to Ms. Rita Hayes. You may begin.
Thank you so much. Good afternoon, and thank you everyone for joining us for this National Learning and Action Network event, part of our Quality Sharing Knowledge and Improving Healthcare series. We're very happy to have you with us today as we discuss the important topic of advancing effective communication and coordination of care. My name is Rita Hayes, and I'm the lead for Leadership and Organizing and Action for the Quality Innovation Network National Coordinating Center at Telegen. A few reminders and housekeeping items before we get started today. First of all, thank you so much for joining us in the WebEx Event Center. You will need to access your registration confirmation email and your registration ID to log into WebEx. My colleague, Laura Menken, from the Quality Innovation Network National Coordinating Center, or QuinnNCC, will be monitoring our WebEx chat board, so please participate in chat throughout the call today with your comments and, of course, your questions. Slides, resources, and a recording from today's session will be posted on the QIOprogram.org under the News and Events tab. Laura will be posting that link in chat. Some of the resources are already posted, so please be sure to check that out. So our agenda today, we'll be hearing from Tracy Archibald at the Centers for Medicare and Medicaid Services, Dr. Jane Brock from the Quality Innovation Network National Coordinating Center, and Angela Lucinda Prokop from the Southwestern Pennsylvania Area Agency on Aging. After the presentations, we'll have a short facilitated discussion. And we're offering continuing education credits for this call today. I'll go over those details in just a minute. So I'd like to take a moment to remind everyone of the purpose for this important series of learning and sharing events. Without reading all the content on the slide, I'll just mention a few high points. The audience for the series is very broad and inclusive of a variety of healthcare provider types as well as partners and patients. The purpose is to offer virtual learning and sharing events with a focus on ideas and concepts related to healthcare quality improvements. We ask that you all think of actionable ways to implement the ideas and concepts presented today and to make a commitment to share the information with your own teams. And finally, we are always open to new ideas and suggestions for call topics. So please feel free to send your ideas through the chat or through the post-event assessments. And now, to address the objectives for today's event, we're working nationally to prepare healthcare professionals, partners, and patients to implement effective strategies for communication and coordination of care. Through today's event, we hope that you'll identify opportunities for innovation and implementation in your own work with an overall focus to improve the quality of care provided to Medicare beneficiaries. We strive to make these events as interactive as possible, which can be challenging given such a large audience, although we're very excited to have all of you. Truly rich learning is only possible through an exchange of ideas and a commitment from both the presenter and the audience. Therefore, we ask you to commit as individuals to be attentive, active participants, and actionable, thinking about all the ways the content is relevant to your work and priorities. Please check the green check mark in the WebEx application to show your commitment or type yes in chat. Wonderful. Wonderful. I'm seeing some yeses come in. We are also very excited to now be offering continuing education credits to all attendees for participating in today's session. Based on feedback provided during our last session, we'll be offering credit to all physicians, physician assistants, registered nurses, nurse practitioners, dietitians, pharmacists, and pharmacy technicians. We'll also be offering certificates of attendance. Should you have any requests for additional accreditation types, we welcome those suggestions. Please type them in chat or again during the post-event assessment. In order to apply for continuing education credit, you must must have attended the entire event, completed the post-event assessment, as well as the CE evaluation that will appear after exiting this WebEx session. Note, the CE evaluation can only be accessed by following the application site hyperlink at the end of the post-event assessment. If you have any technical issues related to the CE process, please contact Nikki Rasselis. Her email is on your screen on the slides, and Laura is also typing her name in chat. This disclaimer from our partner provider, CRW Associates. This activity awards 1.0 AMA credit hour for physicians and physician assistants. This activity also awards 1.0 contact hour for nurses and 1.0 continuing professional education unit for dietitians. These are the accreditation statements for those entities. We would like to report also that the planners and faculty for this event, CRW and Associates, and Telefon do not have any financial relationships to disclose, nor was any commercial support received for this activity. Please reference the slides for the full disclosures and disclaimers. So let's start by getting an idea of what organization types are represented on the call today. We invite you to respond to this poll. WebEx operator, will you please open the poll? And if for any reason you're not able to participate in the poll, you can also type your answer into chat. The poll is open, and we have about 40 seconds to go. And if you don't see your own provider type, you can choose Other and type in your comments in the comments section what other types of organizations are on the call. That also helps us gauge for future events, who's all attending this call and what topics you're interested in. Thank you so much. So we'll see those polling results in just a few minutes or a few moments. So the session goals for today, by the end of the call, you should be able to identify key elements to help you succeed in achieving effective communication and coordination of care, be able to describe best and promising practices used to bridge community and social support gaps, and explain how you can leverage partners in your own community to help achieve desired change within your own team, organization, or community. So now I'd like to introduce our first speaker. Tracy Archibald is the Director of the Division of ESRD, Population and Community, and Quality Improvement Innovation Group at the Centers for Medicare and Medicaid Services, or CMS. Tracy will talk about the CMS quality strategy and provide an overview of CMS's efforts around care coordination. Tracy, the floor is yours.
Thanks, Risa. So the first slide shows the CMS quality strategy, and this particular event for our National Learning and Action Network call topics aligns with the CMS quality strategy goal of strengthening effective communication and coordination across settings and partners. Next slide. The goal 3 objectives under the CMS quality strategy, as you can see, is promoting effective communication and coordination of care. We're looking to reduce admissions and readmissions to hospitals. We're looking to embed best practices that enable successful transitions between all settings of care, and to enable effective healthcare system navigation in our efforts to improve this area. Next slide. And we aim to achieve these objectives in a variety of ways. The first bullet is encouraging care coordination across the healthcare continuum. And I would say that in addition to encouraging the care coordination, to be very intentional about implementing interventions and measuring the impact of those interventions that you're implementing to see that care coordination is improving through your efforts. The next is promoting a person-centered approach to coordination of care. Some examples of that would be a personnel health record moving with the patient across settings. And then finally, recognizing the positive impacts that having critical pieces of information across the settings can occur. And I think all three of these are extremely important. So I appreciate the time given to introduce this call, and I will turn it back over to Rita.
Thank you very much, Tracy. We appreciate your insight from a federal perspective and knowing how we all fit into a larger picture. And we look forward to partnering with CMS and, of course, all of the participants on the call today in the future. And now it's my pleasure to introduce our next speaker, Dr. Jane Brock, who is the Medical Director with the Quality Innovation Network National Coordinating Center or QuinnNCC here at Telegen. Jane will present a brief history of our journey of care coordination. And Jane, the floor is yours.
Thank you, Rita. So it's a pleasure to be speaking to you all today, and this is actually a topic I find quite interesting, which may tell you more about me than you want to know. So next slide. Is there? Yeah, so I was asked to write a paper, how did we make transition such a big deal, which is how I found myself on the Social Security Administration's website looking at their seriously impressive history pages. They have a whole history section on the Social Security Administration's website, and it's really fascinating. So what's happening now in healthcare is really something that has been in progress, I would say, for probably 80 years. Next slide. So here's go ahead and just hit it again. So here's what we have for numbers for readmissions and hospitals right now in 2016. So the current readmission per discharge rate is significantly down. We've made actually impressive progress. It's now just over 15%. So that means Medicare beneficiaries, fee-for-service Medicare beneficiaries discharged from the hospital, 15% will be readmitted within 30 days to a hospital, not necessarily the same hospital. So 799 is the number of hospitals that are not receiving a penalty for an outlier readmission rate in 2016. 3% is the maximum penalty right now under the Hospital Readmissions Reduction Program. And what that means is a hospital that has a higher than expected readmission rate, has the highest readmission rate, experiences a 3% reduction across all payments. So the policy does not withhold payment for readmissions, but it adjusts all payments to such a hospital by 3%. So 38 is the number of hospitals in 2016 that will take the maximum penalty of 3%. And 52%, our last number, is the proportion of patients in their HCAP survey that strongly agree that they understood their care when they were discharged. So despite huge progress in reducing readmission rates and a wealth of understanding about what that takes, we really haven't made very much progress yet on sort of patients' confidence at the time of discharge. So I think that future directions are going to strongly move in that direction. So next slide. So this is why I found myself on the Social Security Administration history page. So really, when you think about it, this is kind of interesting. So in 2008, 2009, we created a business case for reducing readmissions by creating hospital penalties. And in an odd way, it has been very effective at creating a business case, which was its intention. But when you think about how do we get to the point where we were, having to adjust payments to hospitals, like what appears on the surface is that they should be a gatekeeper for themselves, kind of, which is kind of unusual. So when you look back at this, and I actually had wondered about this before I got onto the history page, so I guess I was the right person to write this paper. We passed the Social Security Act in 1935 or 6. And so when you think about it, It's interesting that there was a huge delay, and Medicare was not passed until 1965, a full 30 years later. And so when you look at the documents around the discussion of the passing of the Social Security Act, it was everyone's intention at that time to include a national health insurance plan as a part of, Social Security. It was widely known, and it was a source of great concern that it was very common in the 30s for elderly people to die in poverty. There was really no safety net, and that was often related to decline in health. The original Social Security Act was supposed to contain a national health insurance, but it proved to be politically so contentious that it was removed. And the thing that is fascinating about this is the rhetoric around what a national health insurance bill would do to the U.S. uses some of the same language you still hear today. So it's going to put a bureaucrat between you and your doctor. It's going to set the government up to be a gatekeeper in your care. I mean, a lot of the language that we still use when we discuss national insurance or single system was really created in the 1930s. So anyway, FDR, who was president at the time, did what any gifted administrator would do. He said, let's carve this out. He appointed a commission to study it, and they passed the Social Security Act without an insurance product. So then it was 1936, and a whole bunch of stuff, including World War II, happened. And we didn't get back to discussing this until about 1948. So in 1947 is when most of the other industrialized countries passed their national health insurance packages, including England. And England was broke after the war, and we were wealthy after the war. But it was really we fell apart on political divisiveness around the role of government in supporting, a national health insurance package. So every administration after that basically tried to get to this notion of some kind of health insurance safety net, and just did not get it done. So in 1960, the Kennedy administration placed this as a high priority on their agenda. And what kind of seemed to happen is there was sort of this groundswell of support for Kennedy's legacy when he was assassinated. And both houses of Congress saw an opportunity to get through a health insurance package for elderly. So there's great sympathy for the notion that elderly people would be dying sick and in poverty. So we passed a bill in 1965 that gave you health insurance at age 65 and forward. So hit the slide again. However, this was passed as a pure fee-for-service program because of the political backlash from medical service providers. So it was passed. This is the first sentence in Title 18, which is the title that establishes the Medicare program. Nothing in this title shall be construed to authorize any federal officer or employee to exercise any supervision or control over the practice of medicine or the manner in which medical services are provided. So it was a pure fee-for-service program, meaning a provider could submit a bill and the taxpayers would send them the payment. And the Healthcare Financing Administration, which is now what CMS is, was established in order to just pay those bills. So the only real regulatory lever that the Healthcare Financing Administration had when this bill was passed was conditions of participation. And I assume folks on the phone are probably far more familiar with conditions of participation than I am. But what that means is that the Healthcare Financing Administration had the right to define who is a service provider. So what is the definition of a hospital? What is the definition of a nursing home? That sort of thing. To state what kind of credentials and services, what kind of credentials a service provider had to have, and what kind of services could be provided within that setting. And that was conditions of participation. So when you think about it, over the past 10 years, we've done a lot of hand-wringing about silos, which is really the reason that we had to create this notion of care transitions as a new way to practice medicine, because conditions of participation meant that there had to be a defined place, a defined provider type, and a defined set of services that could be delivered within that setting. So next slide. So in 2008, it was kind of a red letter year because that was the year that the Affordable Care Act was being written, and it was a year during which there was a lot of developmental work and analyses around the cost of readmissions, specifically to the Medicare program and to taxpayers. So the Sentinel article in the New England Journal, published by Jenks and Williams and Coleman, it was actually published in April of 2009, but it showed that the readmission rate was 19.6% and that we were spending $17 billion on the care delivered during a second hospitalization within 30 days. So this got everybody's attention at a time that there was, will to bring major reforms into the Medicare program. So incidentally, well, not entirely coincidentally, this was also the year that the quality improvement organizations were asked to experiment with methods for using quality improvement techniques to drive improvements in care coordination that could help reduce unnecessary or unwanted readmissions. So I was part of that very early work, and we at that time we started out by approaching this as a hospital-centered program. We were going to work with hospitals to improve their quality to reduce readmissions, but it took about 6 months for us to realize that the the improvement that needed to happen went far beyond the walls of the hospital. So we made a serious step forward when we recognized, and I realized that we were late to the party on this, but we recognized that there needs to be a very intentional and serious connection between hospitals and follow-up social services, at least as much as follow-up medical services. So that's when we first became aware of the area agencies on aging, and we're going to hear from one later in this talk. So going back to history, somebody, that was the notice of the early notification of penalties to hospitals. So when you read the history of Social Security Administration, there were a number of thoughtful folks who were worried from the very beginning that we were going to pay for medical services and sort of ignore this whole social support component. So at the very same time, the Older Americans Act established what is now the Administration on Community Living, but it was the Administration on Aging, because there was a recognition that that medical services alone was unlikely to solve the problem of frail elderly folks. However, it was established so that the Administration on Aging was established as a separate division within HHS with completely separate budgets. So in our work, it was so clear to us that this linkage was important that we were very enthusiastic to see the Community-Based Care Transition Program, which our speaker is going to talk about in a minute, as a first step towards what I would hope someday we would test, which is a full test of shared savings between government-paid medical care and other HHS support for community service integration. So I want to say just a brief word about this notion of community and medical payment coming together. So at the time the CCTP came out, I know I personally got some feedback that some folks found it to be an odd thing to suggest. So I just did my very own brief little search through PubMed about some of the key components, some of the key concepts to be tested through the CCTP. And as you can see, there's been awareness for a very long time that hospital-centric care would lead to poor outcomes and rising expense. So I would be happy to supply anybody who's interested with all of these references. One of the most interesting of all is this very last one. In 1984, there was a big assessment of Medicare data, Healthcare Finance Administration data, that looked at the readmission rate at that time in the early 1980s, and guess what? It was 19-point-something%. It was exactly the same as what we discovered again in 2009, and the conclusions of that paper suggested that an experiment should be tried to direct quality improvement activities towards reduction in readmissions. Next slide. So just a word about measuring readmissions. So the readmissions measure that is often used is readmissions per discharges. This is our actual data from our very first pilot using quality improvement organizations. And the blue arrow was when we were at the midpoint of this work, 18 months in. And it was clear that we were reducing readmissions by quite a bit. In fact, the actual numbers were among the 14 pilot sites that there were something like 800 fewer readmissions, but the rate was going up. And that's when we realized that if you link with community services, what you get is a reduction in admissions as well as readmissions. So if you reduce the denominator, then the relationship between those two numbers is kind of unstable. It can go down, and it does often go down, but it also can go up. If you're reducing sort of admissions more than 30 days out, more than you're reducing admissions in less than 30 days out. So we have gone, next slide. So the measure that we use in the QIO program is readmissions per 1,000 beneficiaries in a community. So we measure readmissions per person at risk of admission, which we think is a better way to follow sort of community-based improvement towards readmissions reduction. Next slide. In terms of future directions, I think the directions that really are still very ripe for development, I already referred to one of them, which is patient perceptions and satisfaction with care around care transitions, but also this notion of the role of social determinants of health. So currently the readmissions for discharges measures are not adjusted for socioeconomic status or other social determinants of health. And that is because low SES status is also associated with poorer quality care. And so the hospital readmission measures that are assigned as hospital accountability measures are really meant to spur a quality improvement. And so those measures have not been adjusted for socioeconomic status. In terms of our measures, the readmissions per thousand beneficiaries, that measure is provisionally endorsed right now by the National Quality Forum, and we have been asked to look at whether there should be SES adjustment to the measure. So we are actually recommending that it be age standardized, in that some communities acquire younger beneficiaries at this point, which is an interesting time point for the Medicare program. Some communities are acquiring lots of healthy young beneficiaries, and others are losing lots of healthy young beneficiaries as people do sort of what I call lifestyle retirement. So we are recommending that measure be age standardized for improved sort of use as a community tracking measure. We're also very interested in area deprivation indices, which is sort of neighborhood socioeconomic status, as a way to learn how to improve faster. And we don't want to adjust the measure for the neighborhood served, but we want to see how measures respond to various quality improvement strategies based on their sociodemographic determinants, sort of the neighborhood determinants. So, next slide. Really, in the end, the future is exactly as the article, which I put on the other slide, which was published in 1956, says. I think that that our mandate is still very clear. It's exactly the same as it was in 2008, even though we didn't know it at the time. So this was a physician writing to other physicians. We physicians need to acquaint ourselves with all of the facilities available in our communities. If none are available, we should initiate them. We should help coordinate these services and help make the community aware of the needs and potentialities of the chronically ill. So that was the guy who was actually the head of the California Medical Society in 1956, and I think those words are still kind of a guidepost for us today. So thank you very much.
Thank you so much, Jane. We always appreciate your insights and the little history lesson here about our journey through care coordination through the years and where we are now. So I just want to take a minute of reflection and ask you all to reflect on what you've heard so far, what insights you've gained or ideas you've had about what you've heard so far, anything you found interesting. And for the moment, we'll just use chat for that. We're not going to open up the lines quite yet. We'll just take a minute for that while we transition to our final speaker. I'm going to go ahead and transition. Please continue to participate in chat, though, typing in your insights, ideas, anything you found interesting or ironic. And now it's my absolute pleasure to introduce our final speaker. Angela Lucente-Prokop is the Regional Project Director at the Southwestern Pennsylvania Area Agency on Aging. She will discuss their experience with the Community-Based Care Transitions Program, or CCTP, the key elements that help them succeed, and what they'd like to carry with them into the future. And Angela, the floor is yours.
Well, thank you so much, Risa, and thank you to Dr. Brock. I always feel like I'm, feeling so enthusiastic and motivated when Dr. Brock is speaking. I'm scrambling furiously to kind of jot down every word. So thank you very much. So if we take a look at the next slide, I wanted to share with you a little bit about this Community Care Transitions Program's history and partnerships with the Quinn 2.0, and I think it really has a lot to do with care coordination and all of the things that we've been talking about so far today. So if we take a look at the next slide, I won't walk through this in detail, but you can get a sense here of the history and the timeline. And this Western Pennsylvania community has indeed been working with the Quality Insights Organization for many years now. And that came at a time when, as Dr. Brock was kind of orienting us, when this kind of care transitions or this focus on avoidable readmissions kind of hit. And so a couple of these area agencies on aging were brought into these partnerships, and that kind of work has continued, and within the context of the current community-based care transitions program and the current care coordination scope of work. So if we take a look at the next slide. By way of background, I actually won't get into this, but we're all familiar with this information. We're really kind of focused on reducing these avoidable readmissions as one measure of quality and one way of achieving some cost savings and improved transitions in care. And then when we take a look at the next slide, what I really wanted to share here is a little bit about what the community is doing, and we're really serving about 3,500 Medicare fee-for-service patients annually. The community consists of a community-based organization, that's the Southwest Area Agency on Aging, and 6 acute care hospital partners. Those partners are the Monongahela Valley Hospital, Excella Health System, Frick, Latrobe, and Westmoreland Hospitals, the Washington Hospital and Health System, and Allegheny Health Network's Ginsburg Hospital. The community is working across 4-county geography, predominantly rural, 129 zip codes, and there are 12 coaches, generally with a background in community and social services, and they're hired by the community-based organization in order to provide a health coaching kind of service to patients as they discharge within the community-based care transition scope of work. And so we're kind of focusing in on patients in a really propulsive way with these inclusion criteria and exclusion criteria, and so we're really kind of looking for patients who are at high risk of a diagnosis. And those kind of diagnoses are things we're all familiar with, and they're listed there, or multiple medications, or readmission history, psychosocial risk, or case management referral. There are some exclusion criteria which are driven predominantly by rules of the program, so we can't serve someone that's already been served within the past 180 days, or things that we determined the care transitions intervention did not necessarily have an evidence base for, did not seem to be well suited for. So if we take a look at the next slide, in light of this, we're really kind of targeting patients who are at high risk of a readmission. The most frequent risk factors we find, even from our ongoing tracking, is the 10 things that you see here. They're really not surprising: COPD, diabetes, CHF, etc. When we look at the individuals who are served, we find that it's predominantly adults with disabilities or older adults. They're identified at high risk of readmission. They begin with an acute care hospitalization, and it will also not surprise you that 90% have more than 2 comorbidities, 71%, 3 or more, and 28% 5 or more comorbidities. And while we track this data in our own information system, we also get these hierarchical categorical complexity scores from our quarterly monitoring report and show the range of complexity of the patient population that we're serving. And we were kind of seeing that right between 1.7 to 1.8, which we believe is validating the complexity of the population that we're serving. And I think this is important because this is one of the ways, are we really helping to reduce avoidable readmissions, or are we serving people who weren't going to readmit anyway? So if we take a look at the next slide, in a nutshell, just being kind of mindful of the time, we try to summarize some of the things that we've really learned, particularly some of the things coming out of our partnerships, our communication and collaboration. And you can see that we went from a baseline readmission rate at the top of the slide of 19.9%, and our program-to-date readmission rate among those served is 13.2%. And so, that looks like a really nice reduction in avoidable readmissions. And so we're really kind of finding that what we've learned can be summarized by the way that we work together and the way that we collaborate, the kind of having clear goals and strategies, using these systems to collect and report on data. And those systems have really evolved over time, and they've become more sophisticated over time. But I think the important thing was that we, started anchoring on patient need and data and our root cause analysis at the very beginning, and we continued to kind of monitor that data, look for opportunities to improve, make those decisions together. We have really routine, transparent kind of opportunities to share results. So we have these monthly leadership calls where all of our hospital partners and leadership from the community-based organization are all on calls together. We exchange reports and data. We exchange reports that are both kind of the QuIN-QIO 11 scope of work reports, plus our quarterly monitoring reports, plus additional analyses that come out of the Care Transitions program through partnership with Telegen and the Lewin Group. So it's really kind of a data-rich program which kind of helps everyone to really focus on what kind of interventions are working and where there's opportunities for additional improvement. We think it's really important to always be focused on improvement and to use these kind of rapid cycle tests of change, and obviously to continuously train and strengthen the skill set within the program, whether that's with the coaches, on community services, or anything else that kind of our data is pointing to. If you take a look at the next slide, we can share with you a little bit about some of what we're seeing in terms of our own data in the program. So this table shows you the rates of different elements within the Care Transition Service. So we're using the Coleman Care Transitions intervention, but these measures are a little bit more generic because they're in place by CMS for a variety of evidence-based interventions that communities might be using. So you can kind of see all of these performance measures, 92.8% transition planning support. You'd really expect that to be 100%, and we think that that's kind of a little data entry artifact. Comprehensive medication review and reconciliation. I just heard a fabulous QIO Learning Action Network call within the past couple of weeks, and I was talking to our team, and it turns out that this 86.9% rate of medication review is because we're not doing MedRec for patients who are at a skilled facility. And I think it was Tracy that may have said, this is absolutely something that you should be doing, and the supervisor for our Care Transitions coach team raised this just the other day in one of our meetings, and said we should absolutely be doing this, and here's why. So, kudos to the team for sharing that kind of good information on these calls. I think it really does inform communities. You can see also the level of caregiver engagement. We think that 68.3% is actually quite good for engaging patients' families and informal caregivers and other kind of counseling and self-management support. So if we take a look at the next slide, we can talk to you about some additional benefits to participants. So on the whole, based on the sources that you see at the bottom of the slide, we're looking at quarterly monitoring report, which is the claims data that CMS and Mathematica provides to us. We're also looking at our own information systems where we capture data on our intervention and any outcomes that we're tracking. And we're finding between a 16 to a 45% lower 30-day readmission rates, a 23% increase in patient activation, a 23.14% increase in 7-day physician follow-up. And because of the claims data that we're given, we're able to look at the benchmark of all care transitions communities nationally, but also the baseline for our partnering hospitals and kind of setting goals and being able to track progress. You can see a similar kind of measure for the 14-day rates, and 71% of the people that we serve receive information, referral, or assistance for community services. And on the next slide, we can take a look at just what those community services are. So we started about a year and a half ago collecting the data on how often were we making those linkages to community and social services and what kind of services those were. And so you can see just some general service options. We call that options counseling, providing an overview or a resource guide. Following up on home health, we find that There are times when a patient might decline these services when they're in hospital, and whenever the coach goes into the home visit, they realize that, they actually probably do have a need here, and then they explore it a little bit and find out they've declined it, and so that's why you're seeing that show up on the list of most frequent community supports. Also meals, assessments, transportation, volunteer caregivers, and caregiver supports. These are just a sample or the most frequent things that have come up in the past year and a half, but we do kind of look at this routinely. And if we take a look at the next slide, we're also capturing patient activation results. So you can see that this is very much the Pullman patient activation assessment results. You can tell by seeing the 4 pillars there. And this is just a little sample from our information system. We're able to pull these little snapshots. And we can do this by hospital or by health system or by the whole community. And you can see the initial and then the final and the percent change in each of the 4 pillars of patient activation, and then the overall change in scores. And so this is like 3 hospitals and a health system that's kind of being reflected here. And we can take a look at the next slide. One of the great things that the community also evolved to do is these readmission reviews. And so who's participating in these readmission reviews has kind of changes on time, based on time, competing kind of interest, rollouts of new information systems, different kind of practical considerations like that. But the community does these readmission reviews for the purposes of better understanding what's driving readmissions and what can we do about it and what is avoidable or potentially avoidable. And so you can see in terms of the general process flow, we have these routine scheduled events. They're either weekly or every 2 weeks, depending on the site and the volume of readmissions that need to be reviewed. There's a pre-readmission review report, which basically captures some general information on the readmissions to be reviewed. On the call represents folks from the hospital, usually the case management lead or the director of case management and quality, an advanced practice clinical consultants within the community-based organization, the coaches, the coach supervisor, and the coaches, I should say, that includes the field coach that serves the patient in the home and in the community, plus the hospital coach that had met with them there or was looking at the data and making enrollment and referral, those kind of things. So there's a standard data capture that's happening with regard to the patient's intervention, and then there's some summary report and so on that the leadership team can use to learn from these readmissions. And then if we take a look at the next slide, this gives you a little bit of insight on what we're looking at for standard data capture. There have been some challenges in being able to make this a little bit more user-friendly. So, we have a rich amount of data in our information system, and we've been challenged in being able to get it out in a real efficient way. But you can see that there's some rich potential here to analyze root causes of readmissions. And most of this data is very quantitative in nature. But you can see it in all 4 of the pillars: medication discrepancies, patient activation, risk factors, and then there's some conclusions that are probably more qualitative in nature. If we take a look at the next slide, and the intention is that these would really provide communities with some practical insights on how you might approach readmission reviews yourself, or just a comparison. Probably a lot of folks are already doing this and probably doing it even in a more sophisticated fashion. This represents our medication discrepancy tool, so you may recognize this from the Pullman Care Transitions Intervention. We have this just kind of built into our information system so that when a coach identifies any kind of medication discrepancy when they're reviewing medications in the home, they're able to identify, is this a patient-level cause or contributing factor, is it a system level, and if so, which specific reason is it? And you can see a variety of reasons there. And we can take a look at the next slide. And I was asked this kind of great question. So what would be our dream scenario? Certainly, our community is one of the community-based care transitions programs. Our scopes of work are wrapping up in this calendar year. So I think all of these communities are ending their work by January 1 of 2017. Our community's funding ends in September 30th of this year. Our dream scenario is to continue our partnerships. We believe we're adding a great deal of value together. We'd like to continue the journey in some fashion. We're looking forward to always making a bigger impact, making the unavoidable avoidable and the impossible possible. We're really dedicated to continuously improving, and we're working very actively with all of our partners to identify some additional contracts and sustainability beyond the demonstration project. So that's the end of our sharing, and so I'll turn it back to Risa to give the Learning Action Network a chance for some facilitated dialogue.
Thank you so very much, Angela. And nice job getting through a lot of slides and a lot of really great info. And, you know, personally, it didn't feel rushed to me. So I hope that's the case for everyone else. I did see some interesting questions come in. So let's go ahead and start our discussion with the time that we have left. And please feel free to participate through chat, of course, with your questions, your comments, as well as by phone. And our operator will also remind us of the instructions, but you can press *1 on your telephone keypad to enter the queue, and basically we'll take people in order that they enter the queue. So while we're waiting for you to queue up, I do have some questions for you all that you can also enter in chat, and I'm going to type them into chat myself for those of you who are visual like myself. And I apologize ahead of time for typos. I was doing it while advancing slides. But just some questions to get us started. I'd love to hear from you about how you are addressing communication and care coordination already in your organizations and with your partners. And especially what challenges you face and how you overcame those challenges. I've also been involved in this work since, well, starting with 2008 with Jane. And I know that there can be a lot of challenges when it seems in so many ways so important and so common sense to get together with your partners, but it's not always easy. And also, what single piece of advice would you give to organizations who might be just beginning to focus their efforts on this type of work? And I'll also extend that to our speakers if you want to chime in as well. But I'm going to go ahead and ask our operator if we have anyone in the queue.
Again, if you would like to ask a question, please press *1 on your telephone keypad. We do have one question from one of our participants whose information we were unable to gather. Caller, if you ask you for a question, your line is open. Please introduce yourself.
Hi, this is Jeff from Seattle. Can you hear me?
Yes. Hi, Jeff.
Hi. Yeah, the question I have is for Angela regarding the readmission reviews that you were doing with your community. Were there any other triggers that you could think of that, besides hospital readmissions, that would be reviewed by a community care transitions community on a regular basis? One of the challenges we find is that sometimes hospitals feel like they're being picked on. It's the only organization that gets dinged for readmissions when, as Jane said, it's the whole community is dealing with the issue of care transitions.
Yeah, that seems like such a great question. So as a community-based organization within the context of this program, the only kind of trigger events that we are reviewing is a readmission review. But that said, we recognize that there's a lot of different kind of quality reviews and so on that are happening within the broader context at the hospital, and those we're not a part of, but I'm quite sure there's a great deal going on.
I didn't know if there were any other facilities like home health agencies or SNFs.
Yes,
other people
sorry.
that could have their own little deals that say we'd like to have this reviewed as well as part of the care transition.
Yes, you know what? You're causing me to remember that at one phase of our community's development, there was actually some great reviews that were happening that were between the health system and the skilled nursing facility and home health providers within that community. And for a time, we were sitting in on those as well. And then I think those happened for probably 6 to 9 months. And then I think they had moved on to another kind of phase of their development. But they were doing that very thing. They were reviewing readmissions together and then having maybe some deeper case reviews. And they had established a private dedicated line for this. And it seemed like it really added some value.
It seems like a really good way to structure and give a purpose for community-based meetings that are actionable. So I like the idea.
Yeah, absolutely.
Wonderful. Thank you. Thank you so much. And we do have some questions in chat. But operator, do we have anyone on the line in the queue?
I do have another question. So the line doesn't participant with information you're unable to gather. So if you have a question, your line is open. Please introduce yourself.
My name is Rose Eckel, and I don't know if this is a valid concern or not, but I would be, in the hospital there's a social worker who comes along and says, how are you feeling? Do you feel like going home? Well, if I wanted an extra couple days vacation with served food, I think maybe some people are taking advantage of this.
Do any of our speakers want to speak to that?
This is Jane. Hi Rose, that's a great comment. The hospitals, there actually is there's a huge amount of regulation on who can be in the hospital. So this is a holdover from conditions of participation, and the hospital is often. Well, they can keep anybody indefinitely if that person agrees to stay, but they won't get paid by the Medicare program if the person has met certain sort of definitions of clinical improvements. So there are situations in which hospitals do keep patients far beyond the time they are being paid to keep them. Because there's not a safe place to send them occasionally, and that is.
Well, then, who pays then?
Well, in the end, I don't know. The hospital absorbs the cost.
Oh wow!
Yeah, so that does something happen.
I will be a patient myself come tomorrow, and if I want to go home, I'll probably say, yes, I'm ready to go. But as I said, there are some people that will take advantage of this.
Well, and I often, and this is why I feel so strongly about this medical and sort of community service provider link, because there are people who find themselves in severe medical distress that do not have a safe place to go after hospitalization. So if clinically they don't qualify for ongoing medical treatment within a facility, it's a fairly expensive situation, but they have, an unsafe housing situation, it's a dilemma for the hospital, for the person, for their family, if there is family, all of that. And, that's why I'm so interested in forming these strong linkages between community support agencies, including, housing authorities. So that is a situation I think that occurs in areas where there are folks without a lot of resources.
Thank you.
Yeah, you're welcome.
Thank you. I'm going to go ahead and open it up to Laura, our chat monitor, to call out some of the questions that we received in chat.
Thank you, Lisa. There are a lot of really great questions in chat, and I know we only have a couple of minutes. But one that I've been receiving several times is really just around the reasons why patients are readmitted within 30 days. A couple of people have provided some offerings there too, and like social determinants and demographics impacting readmissions. And really just some communities and facilities are faced with greater challenges. So I just wanted to open that back up to both of our speakers and see if you have any additional thoughts on that area.
I'll take a first shot at this, although I have a feeling Angela has far more nuanced information than I have. But, you know, there are a number of risk prediction models where people have put numerical frameworks around the characteristics of any given patient that tells you whether that person is at high risk for readmission or lower risk for readmission. But stepping back for a second, you know, conceptually, the reason people are readmitted is when their burden of living with their medical condition exceeds their capacity to do so. And so at the time you're discharged from the hospital, depending on you know, what your degree of medical challenge is, laying that on top of the degree of just life challenge that you do or don't have, if it exceeds your capacity to take care of yourself, then I think that you end up being readmitted. So somebody with just serious medical burden, you know, somebody who's just really, really sick, and has been to the hospital for acute care services and is stable and discharged with huge medical burden. Now, if that person is incredibly wealthy and can hire a staff of private nurses, they probably will do fine. I mean, they, you know, probably won't need to be readmitted. On the other hand, if that person does not, is not in a situation to hire staff of private nurses, they may not do fine. Alternatively, if somebody lives in a seriously distressed environment, it may not take very much additional medical burden for them to you know, need acute care services again. So the standard risk prediction models take things like number of chronic diseases. So, for instance, people with COPD have very high readmission rates because, you know, they get home and they're not comfortable with how they can breathe, and that's a, you know, fairly urgent situation, and they go back to the hospital. There are other clinical conditions that have relatively high readmission rates. People who are very old and live by themselves often are less able to cope. And anyway, there's a lot of risk prediction models that have tried to place numbers around this. But the risk prediction models that I am familiar with are only accurate about 75 to 80% of the time, because there's just lots of situations that you can't quantify that lead people to be overwhelmed enough that they have to go back to the hospital. So, Angela, you can speak from direct experience on what overwhelms people. I encourage you to comment.
Oops, sorry, it helps if I take myself off mute. I don't know that I can add much to those comments. I think that, you know, that's certainly consistent with our experience. There's certainly a lot of clinical complexity involved, but then there's also social needs that are happening, or just end-of-life complex care needs, you know, and really a mixture of things happening. And so we tend to focus on, there may be some unavoidable characteristics that are going on in a given readmission, but what ones might we be able to have an impact on? And so we try to identify those. And they tend to be a communication piece, following up with a medication that's a discrepancy, a patient running out of oxygen, you know, a home support that kind of needs to be in place, offsetting some, you know, some insecurity, whether it be kind of food or electricity or, you know, other things that might be going on in their lives. I mean, we just really try to make a difference where we can, and we feel like it factors into the bigger picture.
Thank you both so much. Gosh, we only have a minute left. Just very quickly, call to action. You know, we've heard all this great information. We're looking to the future. So we really just want to invite you all to take some action, whatever works for you. Some things that came to mind for us, first and foremost, get connected. Know who your partners are. Contact your state QIO. Find out if there's a community coalition in your area or possibly a readmissions committee that might be meeting, or possibly start one. Of course, look at your own processes and absolutely talk with your partners, not just those that you may have formal agreements with. But think about who else your patients, clients, residents interact with, and who else you need to connect with. And of course, not only looking for what can be improved, but also looking for what's working well, whether it's in your own process or someone else, a partner, or even a competitor. Look for those positive outliers, which can often inspire and teach us much more than even the most glaring gap. And we'd love to hear from you. Share what you will do or have done with us in the next couple of weeks. Again, again, emailing Nikki Versellis, and we'd love to feature you on a future LAN event, perhaps. And speaking of the future, call for future topics. We definitely want to hear from you. If you have ideas, type them in chat or put them in the post-event assessment. And then save the date for the follow-up event for today's call. There was a lot of really great questions that we didn't get to. So we'd love to pick those up in our follow-up event in June on the 7th. Registration is required, so you can register there at the link on your slides. And Laura also put it in the chat. So, as time is running out, I also want to remind you all, please take the time to fill out the post-event assessments. If you're looking to claim CEs, also go through the evaluation for the CEs. And thank you all so very much. Thank you to our speakers. And again, thanks for a great call today.
This concludes today's conference call. You may now disconnect.